So good afternoon, everybody, and welcome to the second webinar in the series on rapid reviews of essential medicines for COVID-19. My name is Trudy Leong, and I'm from the National Department of Health's Essential Drugs Program that is essentially striving to improve universal access to medicines through an essential medicine list. So the topic that will be presented today is, as per the advertorial, on vitamin C and mucolytics to treat COVID-19, as well as updated guidance on COVID-19 testing. Please do post your questions in the Zoom question and answers that have been provided. And please note that the panelists will answer your questions at the end of the webinar. Kindly note that all delegates, you're muted off and your video is also turned off. We've got an evaluation form that can be completed at the end of the webinar, and a link has been provided and will also be screened during the session. So now I would like to introduce you to our moderator for this session, Professor Andrew Parrish, who's the current head of the Department of Medicine at the East London Hospital Complex. His portfolio is quite wide and includes, amongst others, historic as well as current, being chair of various committees and subcommittees. And he also was a clinical advisor for Discovery Health, counsel for College of Physicians, and a member of the previous MCC clinical subcommittee. He specializes in evidence-based medicine, and he also has a keen interest in rational medicine use and knowledge translation. However, before I hand over to Professor Parrish, I would just like to show you a schematic presentation of the systematic rapid review process that already has been briefly described in the first webinar session, which can be accessed on YouTube via the Cochrane SA website portal. And here is the portal link. So the link to the Cochrane SA portal to access previous webinars. Then I'm also sharing with you the COVID Rapid Review website link on the National Department of Health website, as well as the National COVID-19 guidelines, which are available on the Knowledge Hub. And lastly, I would like to convey thanks on behalf of the National Department of Health, specifically to the NEMLAC COVID-19 Therapeutics Subcommittee for their hard work, dedication, and efforts, to Cochrane SA and the SA Medicine Research Council for partnering and hosting these webinars. Also, thanks to Grade SA Network, which are essentially made up of methodologists from centers such as MRC, Cochrane SA, and Stellenbosch University, as well as other reviewers for supporting the rapid review process. And a huge special thanks to the COVID NMA team for providing globally accessible, up-to-date COVID-19 living reviews, HERO for supporting with economic evaluations, and the Better Health Program South Africa for supporting the webinar series. Thank you very much. Over to you, Professor Parrish.
Thank you, Trudy, and welcome to everybody for joining us in the second webinar in the series. I hope you find it illuminating in some of the areas that we are trying to cover. We are really going to stick to the format that we used previously, which is essentially two speakers with a question and answer session at the end, which will really be dictated by us choosing questions which seem like of most interest to the broader group of people who have joined. So without further ado, then I'm going to go ahead and introduce Dr. Nell, who's an infectious disease specialist from the Gauteng. He's in the public sector there, and he's been on our committee for some time as a really very useful member of that group of folk who've been doing these rapid reviews. And I think he is very capable of taking you through this subject on the vitamin C. So over to you, Jeremy, and let's sit back and enjoy.
Great, thank you very much, Andy. So I'm going to talk a little bit about vitamin C in terms of the rapid review that was done by this committee. It wasn't done by me, actually. There's three authors at the end who I'll acknowledge, but I'm going to give you the sort of high-level summary to hopefully show where we're coming from in terms of our recommendation for vitamin C, not just what it is, but why we say what we say in our recommendations. It's got quite a storied history, and it's quite a good topic for evidence-based medicine in general. This idea of vitamin C for colds and for respiratory tract illnesses was popularized in the 60s and 70s by Linus Pauling, who was certainly one of the most gifted chemists rather of the 20th century, won Nobel Prize for much of his work, but it wasn't obviously in this field. And he became a real sort of promoter of vitamin C, this idea that it would solve all common colds. I think he even said, based on his personal experience, but I think he took 18 grams a day of vitamin C, and he felt so much better that he felt that the research wasn't being popularized enough or pushed enough, and on the basis of quite scanty research, made some enormous claims about vitamin C being able to eradicate colds from the face of the earth and people being able to live 25 to 35 years longer free of disease, for example. Quite extravagant claims, which really haven't been borne out by subsequent research. Perhaps a good summary of where we're sitting with vitamin C in general in terms of common colds and respiratory tract illnesses is this Cochrane review of 2013, and give you some sort of a sense of the background of where vitamin C sits in general and why people thought it might work for COVID. It turns out if you take regular supplementation, and this is among general community members, at least according to this systematic review and meta-analysis, it really doesn't seem to do much in terms of your prevention of common colds. And you can see that this is a relative risk of 0.97. with a confidence interval that stretches from 0.94 to 1, which is another way of really saying that the best estimate is that you get about 97% of the same number of colds as people who don't take vitamin C, although we can be relatively confident that the true results, the stretches anywhere from 94 to no difference at all. So it really didn't seem like it did much in the general community, but then you get a really interesting thing if you start looking at people who have a brief exposure to heavy acute physical stress. And these are trials in marathon runners, soldiers, in subarctic operations and skiers. So really kind of a strange subset of people. But in this subset, you do seem to see a different result, at least from some of the randomized trials that are done, suggesting benefit. And remember, this is regular supplementation. This is taking it every day on the hope that you'll fend off colds. And that raise a bit of a question as to why do you not see that in the general population? Well, a number of things. One is that it might work by preventing exercise-induced bronchospasm, actually, which is a really interesting theory. So not so much colds, but just preventing the bronchospasm that goes with a strenuous exercise. But even if it does work, it doesn't really seem to work to people who are exposed to long-term physical stress. It really, if it does anything at all, it does it for the subgroup of people who have short exposures to high amounts of physiological stress at all, but really doesn't seem to do anything for the general person in the population. The other thing is that was the amount of colds. This is the duration of colds. You do get a sense if you pile it all together, the evidence, at least from this meta-analysis, that it perhaps reduced the duration of colds by about 8% in adults, a little bit more in children. Remember, that equates to just about half a day or less, depending on the duration of the cold itself. So really not a hugely clinically relevant improvement. And again, it's driven by that same subset of people who do crazy things for short periods of time. And then the other interesting thing about it is that if you take it, this is long-term supplementation, if you take it therapeutically, in other words, when you have a cold, you start to take vitamin C, it doesn't seem to do anything there either. This is a nice way to introduce the forest plots for those of you who are not aware. I view this as a line of futility, this vertical line going up here, really showing that whether you take it or not, it does nothing. Anything to the left of that line suggests vitamin C might have a benefit. Anything to the right suggests that vitamin C, if anything, harms. So in other words, the placebo has a benefit over vitamin C. And what you're looking at here is the 1, 2, 3, 4, 5, 6, 7 trials. And you can see not just the point estimate, which is this middle thing, this box or the line in the middle, but really a better way of looking at it is looking at the confidence interval, which is the kind of range of real world results that this data is compatible with. In other words, if this trial suggests here a benefit for vitamin C, this particular one, but the confidence interval there ranges on the right from anything from minus 26%. In other words, it favors the duration by, if you take vitamin C, is 26% less, all the way to just about 4%, 3.98%. Whereas if you look at some of these other trials, they favor placebo. And if you bung them together at the bottom here, you can see the overall result which is a really tiny point estimate benefit of less than about 3%, so about 3% less time, but a range of confidence interval that goes from anything from -8 to plus 2.3%. So again, you're looking here at something which really doesn't seem to suggest overall any significant benefit. It may cause a small decrease, it may cause actually an increase. The results are all compatible with that. What you don't see is any significant difference. And then people looked at vitamin C and said, you know, is there any plausibility to this? It does seem to have some effect on phagocytes. It does seem to have some effect on chemotaxis of leukocytes. Even in some preclinical trials, it seems to potentially affect viral replication, interferon production. And then perhaps more plausibly is a sort of good antioxidant, so might help with oxidative stress if you have a physiological stress. But again, you know, the translation between these sort of findings, which are very common with multiple drugs, and any clinically significant difference is very tenuous. And so what you really have to do, despite whether you think it's plausible or not, if you think it's plausible, you really have to test it in the real world and look at it in COVID-19. So that's what this committee has done. We've looked at it in terms of what does the evidence say with COVID-19. Treaty did show the process generally, but it starts to make this as transparent and rigorous as possible. It starts with an assessment of what we call the PICO, the Population Intervention Comparators and Outcomes, which will guide what sort of trials are analyzed. So this is really just saying, if we're fishing for evidence here in a systematic way, who are we looking for and what are we doing? So in the population, we looked at anyone who had SARS-CoV-2 infection, regardless of age. Vitamin C was the intervention that we were interested in the trials with. No restrictions on the dose, frequency, or timing. So any dose, frequency, or timing could be included in this review. Comparators could be any comparators. So standard of care, for example, or placebo would be great. But even if it was an active comparator to another intervention, it was included. And then the outcomes of interest are the things that we'd really care about if we're trying to recommend vitamin C at all. Things like, does it prevent death? Does it prevent hospitalization? Does it shorten hospitalization or ICU stay? Does it shorten your time on a ventilator, if that's what it comes to? And what sort of adverse events occur when you take it? And then looking really at systematic reviews of randomized trials and randomized control trials themselves. And this is, again, is important for the reasons which we covered in the previous webinar about this being the most robust evidence in theory in terms of this trial design. So what happened when the team looked at this is they first found about 275 papers, and that was by searching through multiple databases and searching through PubMed, searching through Epistemodnikos, I hope I got it right, through Cochrane Library and COVID-NMA, which is a really useful resource which has popped up with around randomized trials in COVID. And from all of that, they found about 275 initially, and then removed as you went on through the process. For example, some of them were duplicates, many of them didn't apply to the PICO, and ended with 6 trials. 1 was a systematic review and 5 were randomized control trials. Systematic review of randomized control trials was that one. And the systematic review didn't include any additional trials. So the trials were really analyzed separately. These were 5 studies, 522 people in total across those 5 studies. All of them were adults, no evidence from children. They were done in 4 countries, the 5 trials, so China, India, Pakistan, and the USA. One of them was an outpatient trial looking at mild disease, obviously, and then the others were inpatient trials looking at severe and critical patients. So a real mix again. The dose ranged anything from 2 to 24 grams per day, which could be given orally in some trials or intravenous in the balance of them. And then vitamin C was compared to the standard of care in 3 of the trials. But to placebo in another trial, so zinc and placebo in another trial. And then this drug called ruxolitinib, which is a tyrosine kinase inhibitor, as another drug. So it was in that last trial, vitamin C was actually used as the kind of the comparator to the ruxolitinib. So then once these trials are before the committee, then the members who did this review then did a risk of bias assessment. So they're looking then at these trials, because it's one thing to have randomized trials, but randomized trials can be very misleading if they're done in a bad way. So this is really assessing what we call risk of bias in several domains, 1 to 5, looking at the randomization, number 1, looking at deviations from the intended intervention, looking at how the outcome data was potentially biased through missing data, looking at the measurement of the outcome. So in other words, for example, death, how is it measured? And that seems very straightforward, but when you get to some outcomes such as duration of hospitalization or symptoms or adverse events, it's important to understand how they were measured. And then in terms of how the results were reported, in terms of how they were selected. green is great. Orange or yellow, there's some concerns, and then high risk of bias in the red. So if you look at this this Chow paper, for example, from 2020, the high risk of bias in terms of this third domain, which was missing outcome data, because, for example, he had 43 people that they randomized, but they only reported on 41 of them. So those 2 people, especially in a small trial, are important because it's a relatively big proportion of the overall trial, and not reporting on them could bias the results quite a lot. Some of the other trials differed, for example, in if they were registered on a registry, some of the way the results were reported differed from what was pre-registered. And there were a number of other minor issues. When you can see, if you look overall, none of them got green all the way through. Most of the trials had at least some concerns, and Chow, because of that issue with the missing data, had significant concerns. So that's got to be borne in mind as well when you see the results as we go through them, because this does speak to how reliable they are. And there's some issues. It's not the worst set of evidence we've ever seen, but there are issues with some of the trials which may lead to biased results. We're talking biased in the statistical sense, in terms of statistical bias, rather than, we're not talking necessarily about psychological bias or anything else, although that may feature in as well. So if you look for mortality, does vitamin C prevent death? If you look in terms of the mild subgroup at the top here, this is really only one trial, and you can see this is giving you any result you might care to be interested in. In other words, this is really not helpful in the slightest, this trial. What you've got is 1 death that occurred with the vitamin C arm, 0 deaths occurring in the control arm. These were all mild patients, so you wouldn't expect a lot of deaths. And what it gives you here is this confidence interval that stretches from 0.13, in other words, saying you've got an 87% reduction in mortality, all the way to 74, which is a 74 times increase in mortality. So really, the range of sort of results that this trial would be compatible with is so broad that you really can't say anything much about mortality, but there certainly doesn't seem an obvious signal of mortality there in this very small trial. If you look at those who had severe disease, so severe or critical, so these are inpatients now, these other trials. If you look over here, some of them showed, this is the line of futility, remember, in the middle, some of them showed pretty much no benefit to this point estimate right in the middle. Some had a point estimate that minorly favored vitamin C, but all of them had these confidence intervals which crossed that line of futility. In other words, meaning that overall, when you put it all together, you end up with a confidence interval, anything from 0.38, so that's 62% reduction, to 1.21, which is a 21% increase in mortality. So again, the range of results from these very small trials, often with very small numbers of endpoints, which also adds fragility to these results, is really far too broad to give any clear answers. What you can say is that there's no clear evidence of an reduction in mortality from vitamin C. All of these estimates, their risk of bias notwithstanding, cross that line, which suggests that you can't at all be confident that there's any benefit to the mortality there. If you look at progression to hospitalization, again, just one trial, because obviously it was just the one trial which was from outpatients, again, didn't seem to suggest any benefit there in terms of risk of progression to hospitalization. They had 2 in the vitamin C arm versus 3 in the control arm, which again gives you these enormous confidence intervals, which are really not helpful, and certainly no suggestion of benefit despite that. Duration of hospital stay, again, you can see how the 3 trials panned out, and again, really not looking at, it's very low certainty of evidence, but again, no clear evidence of benefit. If you look at ICU stay, again, the mean difference was increased. In other words, if you gave vitamin C, they had slightly more days in ICU, but again, with an enormous confidence interval and low certainty of evidence. So again, no clear benefit is really what you can say from that evidence, and not much more. And then if you ended up on a ventilator, was it any shorter? Well, not really. Again, enormous confidence intervals and a point estimate that really wasn't clinically different from what you'd want. This is a median of 0.8 with enormous confidence intervals. So again, you're seeing this recurrently. All of these results are showing more or less similar and in some ways frustratingly uncertain results, because they were small trials, despite them being randomized trials. They had often very small numbers of endpoints, and when you put it all together, unfortunately, they don't offer you a huge amount of certainty in terms of the results. But what you can say, at least at the minimum, is that there's no clear evidence of benefit to vitamin C. If you look at adverse events, there were 2 trials that reported them only out of 5, which is a big problem. Only one of them actually had numerical results, so they actually tabulated the problems in this. In this trial, they showed increased amounts of flushing, headache, nausea, vomiting, tingling, etc. Read that list. But again, the evidence very uncertain. There's relative risk enormous, 37, but again, very wide confidence intervals. So again, suggesting probably they did get more side effects, which is plausible given the high doses of vitamin C used. But again, low certainty of evidence. It's very difficult to know what to make of that. And then this other trial at the bottom there actually just verbally said that none of the patients experienced adverse events, but didn't tabulate that in a sort of numerical form. And then just for completeness, those trials were against placebo or standard of care. If you compare it to zinc, just one trial there which didn't show any difference in mortality or progression to hospitalization. And then if there was this other trial with ruxolitinib, which if you look at from the vitamin C perspective, seemed to say that vitamin C showed increased mortality and without any difference in hospitalization duration, an increased duration of mechanical ventilation. But again, two things there. One is that it's very low certainty evidence for all of that. So we wouldn't really want to put any money on those findings. The other thing is that it was an active comparator. So vitamin C may look worse because ruxolitinib was good. So that's always the problem when you have an active comparator, is that it's very difficult to know whether the result you're seeing is from one side of the equation or the other. But again, consistent through all of these, no clear evidence of benefit. So the conclusion from the committee was that in randomized control trials, vitamin C, whether it's compared to placebo or standard of care or zinc or ruxolitinib, really hasn't demonstrated an important reduction in clinically relevant outcomes. Its use may increase adverse events like we showed, and that the current evidence is not sufficient to support the inclusion of vitamin C to treat confirmed SARS-CoV-2 infections. As always, with all of these reviews, it will be updated as new randomized control evidence comes through the vitamin C. But I think we're sitting more or less how it looks with the common colds, in that there really doesn't seem like there's any striking evidence of benefit, either in outpatients or inpatients. So just to acknowledge, most importantly, the three authors of this review, Gary Rubinson, Solange Giroux, and Elsie Marie van Straten. They're the people who wrote this review and did the hard work. The NEMLAC COVID-19 subcommittee as a whole, the National Department of Health, the Secretariat specifically, and then these reviews, as all the rapid reviews are available, they are at this link, health.gov.za, and then the COVID-19 rapid reviews. You can Google that link as well if you'd like, and we'll put it in the chat, I'm sure, as well. You can access all of the rapid reviews. They are transparent and open, and you can see why we say what we say and see what you think of it. And then the useful resources as well, the rapid reviews we've already had, the clinical management guidelines are available both at NICD and the Knowledge Hub website. There's also this one-pager which was designed by the Department of Health in conjunction with Right to Care and USAID, which is for patients with mild disease. It's a kind of one-pager that really aiming for primary healthcare level, which can be accessed from Knowledge Hub there. There's COVID NMA and Epistemonikos, which are some of the two resources in terms of randomized controlled trials in COVID-19. Thank you very much, and back to you, Andy.
Thanks very much, Jeremy. I think you covered that beautifully. We've got through the first of our presentations, and because of the format, what we're going to do next is move straight on to Dr. David, who's an infectious disease specialist in KZN. She's also been a stalwart member of our team looking at these rapid reviews, and is very knowledgeable in the area of HIV and AIDS, and also the other infectious diseases that we see so commonly in South Africa. So she's going to tell us a little bit about mucolytics, and it's over to you, Halima. Thank you.
Thank you, Prof. Harish, for your kind introduction. So today I'm going to give you an overview on the process that we went through to look at whether mucolytics would be helpful in the management of COVID-19 patients. But before I start, I just want to give you a reminder about what we discussed previously in terms of how we develop essential medicines. Essential medicines satisfy the priority healthcare needs of the population. And if we deem a medicine essential, everybody needs to have access to it. So the National Essential Medicines Committee was established a subcommittee to provide input on medicines for COVID-19. And this was to generate evidence reviews to ensure that we have very robust evidence. So the way this committee functions is that they actively monitor evidence sources or any new signals or any new therapeutic options. Then it comes to the subcommittee who then formulates the PICO. You saw in Jeremy's sort of review, the P is for population, I is for the intervention, C is for the comparator and the outcomes. And then once the PICO is formulated, a review team gets together to look at the evidence, and this needs to be generated between 7 to 21 days. It comes to the subcommittee who reviews and makes a recommendation, and then a report is generated, and these are the reports that we're referring to that you can look at, and then it's disseminated widely, and the cycle continues as new evidence becomes available. So the framework that guides an update of the review process is this framework, and we discussed it previously. So just to remind you that this is within which the framework all our rapid reviews fit. So the context of this review was there was a query to the Ministerial Advisory Committee regarding the role of therapeutic bronchoscopy following a publication in the management of COVID-19. And the main thing was this an effective strategy to remove mucus and improve outcomes? So the MAC submitted that there was a lack of evidence for therapeutic bronchoscopy to remove mucus, and then requested that the subcommittee conduct a review of the evidence of mucolytics in the management of COVID-19. So the question was, should mucolytics be used for managing hospitalized COVID-19 patients? And what we compared mucolytics to was to no intervention or an alternative intervention. So currently we looked at what are the available formulations on the South African market. And they were oral formulations, acetylcysteine, which was available both as oral and injection, bromhexine, which is oral, cysteine, oral, and then there was an inhalant solution for nebulization, which is Dornase alpha. So when we looked at the studies that investigated bromohexine, they used an oral dose of between 24 to 96, and this presented the first problem in that the available formulations on the South African market were 10 milligrams per 5 ml as a respirator solution, and then 4 milligrams per ml as a linctus, with 5 milligrams per 5 ml of oxyprenylene. So when we looked at the literature, there was a Cochrane meta-analysis that contained 2 randomized control trials. These 2 trials, one was from China and one was from Iran, that showed a significant uncertainty whether bromhexine is more effective and safer than standard of care or placebo in treating hospitalized patients with mild or moderate COVID-19. The patient cohort in these studies mainly consisted of men. The median ages were between 60 and 50 years respectively. And this table basically summarizes the absolute effects in terms of outcomes. So when you look at clinical improvement, if you just look at it and eyeball it, it seems that the absolute effect of or risk with bromohexine is better than when you look at it with standard of care. But when you look at the relative effects and the confidence intervals, you can see that it crosses null. And the quality of the evidence, there were very small numbers. So the study from Iran had 18 patients. The study from China had 78 patients, and this was deemed very low quality evidence. And I'll tell you more about why very soon. And when you looked at adverse events, there were generally not many adverse events reported, but we do know that these drugs have adverse events, and I'll just indicate to you what they are very soon. So there are 2 doses of bromohexine used in the 2 trials. And the meta-analysis was underpowered to detect a mortality difference as to whether bromohexine is of benefit in decreasing time to clinical outcome by day 28 or associated serious adverse events. And it was limited in terms of generalizability to population. It did not include adolescents, pregnant women, or breastfeeding women. Patients in both studies also received a number of additional drugs in both arms. And the standard of care at that time in Iran was using chloroquine, and in China was using arbidol and interferon inhalation. And these drugs in the Iranian study was not well listed, and hence the two populations were not balanced for us to be able to come to a conclusion in terms of comparators. So the evidence of efficacy and safety is very uncertain at this point. We were unable to detect clinically relevant outcomes of mortality improvement or improvement in clinical outcomes. There's an uncertain risk of serious adverse events. And the outcome measures were consistent with the possibility for clinical harm, and the patients were not blinded. There were protocol deviations in terms of randomization and outcome reporting. The protocol on the website differed from that reported in the clinical study. The trial was conducted in single centers and mainly consisted of men, and it limits generalizability. So the adverse events of bromhexine was gastrointestinal effects. It causes an elevation in aminotransaminase, and then the allergic reactions can be minor like skin rashes or severe like bronchospasm, angioedema, and anaphylaxis. So in summary, the living review of 2 randomized controlled trials were assessed to be very low quality evidence, indicating insufficient evidence to recommend bromhexine for the treatment of patients with COVID-19, especially hospitalized patients. The studies were underpowered to detect clinically meaningful outcomes of mortality or improvement in clinical outcomes, or to detect adverse events. They were open label, unblinded, and reported indirect and imprecise results. So what we concluded that a complete review will be undertaken only when we have further evidence in the literature or that comes to the committee's attention. So the other agent was N-acetylcysteine. There were no randomized controlled trials that could be sourced for either oral N-acetylcysteine or any other mucolytic agent. So then we went to look at, so what do other guidelines say about mucolytics? And the only guideline that specifically spoke to mucolytics was the Australian guidelines. And you can look it up. It says that bromhexine is not recommended for treatment of COVID-19 outside clinical randomized trials. So that was the only guideline that listed anything about mucolytics, but so we couldn't find any other guidance. So just to conclude, there's very limited evidence for repurposing mucolytics for the management of COVID-19. There are currently only 2 randomized controlled trials of bromhexine investigated in adult patients. The evidence currently does not support the use of bromhexine except in a clinical trial setting. And mucolytics can still be considered for other concomitant evidence-based indications in COVID-19. That's for things that it's already approved for. These are our references, and you're welcome to go to the primary references should you have an interest in the studies. And then this is a review conducted by both Jeremy and Trudy. So I'd like to acknowledge their contribution together with the subcommittee and the National Department of Health Secretariat who assist us in achieving these aims, and the review is available at the website. Thank you very much for your attention.
Thanks very much, Halima. And as you can see, a great deal of work has gone into trying to conclusions that we have done. But Dr. Dawood did a wonderful overview of it. So that's where we are with that as well. And we now are going to move swiftly back on to testing guidance in COVID-19. So it's back to you, Jeremy. And I hope we can then have some time for questions and answers.
Great. Let me share screen. All right. So this is just a really quick overview of what's changed in the testing guidelines recently. These are the National Department of Health guidelines available, like you said, the Knowledge Hub or the NICD website. But this is really, it's not an overview of everything in testing, just really what's changed and what's important for people to know in terms of COVID-19 and our latest recommendations. The one is who to test. This is a Department of Health circular that went out probably 8 months ago now, or even longer perhaps. But one of the key things, because people are forever asking, who to test, is the Department of Health actually recommends all hospitalized patients, whether symptomatic or not, be tested for COVID-19. And that's We know that a huge proportion of people are asymptomatic or minimally symptomatic or pre-symptomatic. And obviously within that, to prioritize those people who have symptoms suggestive of COVID-19. But if you're sick enough to be in hospital, the recommendation is actually to get a COVID test, either antigen or PCR, on all those patients. For outpatients, it's a bit different. And we're looking there just for people who have symptoms suggestive of COVID-19. And again, prioritizing a subset within them of those at highest risk of infection. So for example, healthcare workers, or for poor outcomes, it's just the elderly or those with comorbidities. And then the other two groups are one, individuals who are close contacts, again, regardless of whether they're symptomatic or not. And remember, again, there is a definition of close contacts, which is in all the guidelines, which hasn't changed despite the Delta variant whizzing through the population. And the last group, which is very seldom done in practice, but is in the National Department of Health guidelines, is sort of post-mortem testing as well for those who die, so that they can get an accurate assessment of those who have COVID-19. So that's who to test. Just remember, keep calm, don't be silly. Don't test for people for the purposes of returning to work or school or for sports purposes. We've seen a lot of that. Remember that that's not indicated. And patients should not be tested prior to de-isolation. Similarly, it's really more or less a very similar thing. So for example, when people return to work or school, it doesn't make sense to get a test. And people who have had the full duration of isolation as recommended in the guidelines don't need testing at the end of that. Wastes a lot of money and time and causes a lot of needless anxiety. And then the second question, which is very common, is, are there such things as false positives? Now, I framed it in a deliberately kind of inflammatory way, but essentially what the question is asking is, I test positive, I don't think I have COVID, quote, I'm sure the test is wrong. So in reality, of course, you can have false positives. You could have specimen mix-up, you could have contamination at the lab, you could have incorrect results. But in practice, it's basically never rational to assume a positive result is a false positive. And that's because these tests are excellent in terms of specificity. So they really are not detecting other viruses, say, or other autoimmune conditions. If they're positive, they're pretty much always detecting the virus. We know that you can't say, I don't think I have COVID because I don't have symptoms, when most people probably who have COVID are asymptomatic, or at least asymptomatic or pre-symptomatic. And also, you can have a lot of downsides to assuming that you don't have it when your test comes back positive. And of course, if you repeat a test and that repeat comes back negative, that's far more explainable as a false negative. In other words, we know that the testing is not great for sensitivity, so we will miss a bunch of people who have COVID. So a test that comes back subsequently that's negative doesn't then overrule the test that was positive the first time. So again, one positive test is sufficient for the diagnosis of COVID. There's no role for confirmatory testing. So if you get test positive, but you don't, you somehow think this doesn't make sense. Remember, many, if not most people, can be asymptomatic or pre-symptomatic. And so it really doesn't make a lot of sense to say the symptoms don't fit, I can't do this, test is wrong. And that might well apply to other medical conditions, but not COVID, unfortunately. Then what about testing for reinfection cases? Another enormous question that comes up a lot. So we know that you can get infected twice, or sometimes even more than twice, but we do also know that it's relatively rare. If you look through the DATCOV database of hospitalized patients, at least, it seems very small. And if you look at patients as a whole, either in the Western Cape or, for example, some of the private medical aids, again, you don't see a huge proportion of people testing positive twice. It can occur, though, so you do need to consider it. Unfortunately, the only way to really know if it's true reinfection versus persistent shedding, because the PCR can be positive for weeks, sometimes months. And so in that kind of setting, the only way to really know if that PCR that's positive now and positive at some later point is a different virus, or if it's just the same virus again, is to actually take them to the lab, get the clever virologist to sequence them both and show that they're the identical virus. In practical sense, that's basically never possible because people don't keep the specimens, and the virologists, especially in the middle of a wave, are not going to humor you to do this test routine. So what do we advise? And this really comes, it's in our guidelines, but it's really was pioneered by the CDC. To say symptomatic people, if you have symptoms, we recommend testing pretty much from day 45 onwards. In other words, if someone tests 42 days is 6 weeks, so let's say after, say, 6 and a bit weeks, if they test positive at that point, if they have symptoms of COVID-19, it's worthwhile testing them again at that point. Whereas if you're asymptomatic and you have just a lower pre-test probability of this, we really wouldn't recommend testing before about 3 months, which is 90 days there. Now, there are going to be some exceptions. Reinfection has occurred before these markers. So if there are individual cases where there's a strong case to test for reinfection, it's worthwhile chatting to the virologist at your lab or an infectious disease specialist or microbiologist to get some kind of expert opinion as to how to interpret these results. But these are good rules of thumb. If you tested positive, for example, we see sometimes the patient was tested positive a month ago, then they come to hospital and they get tested again and it's positive, and then they get shoved off to the COVID ward. That's really not the right way to do this. If you tested positive before and you've had enough time since your disease for you to be non-infectious, which in mild cases is about 10 days, there's no reason to retest them. You're going to run in circles. So again, don't routinely, at least, retest people before 45 days if they're symptomatic, or before 3 months if they're asymptomatic. Then really briefly, antigen tests, which is a new part of this wasn't in the guideline a year ago, at least. They're not as good as PCRs in terms of sensitivity. They may be about 70% as sensitive as a PCR, roughly, ballpark figure. They are faster and cheaper. And Anne van Gotweg did a really nice talk on this in the Knowledge Hub a short while ago, saying that really the time to use them is whenever PCR isn't fulfilling its required role in terms of public health. In other words, it's too slow to triage the people, or you don't have the volume to PCR. So whenever you need a result and PCR is really not able to give it to you because of its speed or the volume, then that's the time to start considering using an antigen test with the limitations above. A positive result is enough. Again, these are very specific tests. The first guideline from the Department of Health that came out suggested a positive result needs to be confirmed. That's no longer the case. A positive is a positive. Negative result is tricky though, because it may be a true negative, or it may be that's just not as sensitive enough and you have to repeat with a PCR. So the guidance on that is if the person's symptomatic in a way that's suggestive of COVID, or if they're a close contact of someone who's got COVID, or if you're in the middle of a wave, which just means your pretest probability is higher technically, then if it's negative, you should repeat a PCR and confirm. Whereas if none of the above apply, you can probably just rely on a negative result. Some outside of a wave when not a lot of COVID going around, patients asymptomatic, no close contacts, a negative result is enough on an antigen test. So again, interpret them regarding, like I said, in terms of what to do, a negative result based on that pretest probability, like I said, symptoms or contacts or where you are in the wave. And then lastly, these antibody tests, a lot of questions that come in about them sort of persistently. Despite some pretty aggressive marketing sometimes, they really don't have much of a role in the acute setting because they do take 1 or 2 weeks at a minimum to become positive, and many people only become positive much later. Depends which your target is and which antibody you're looking at, which antibody reagents you're looking at. But again, when someone is sick, if they get to hospital, they usually get to hospital within about the sort of 7 to 10 day mark. The antibodies at that point may well be negative, even if you have COVID. So not all that useful. Occasional uses for the antibodies in the sort of semi-acute setting would be, for example, that multi-system inflammatory syndrome in children, which this is a little bit later on in the disease process, often after acute COVID. And there are a couple of other scenarios where it may help. And if you're stuck in, if the patient, for example, is outside, somehow presents outside the window when you think a PCR will be positive. Again, they're not hopeless, but you do have to be careful with how you use them. You also have to be careful after vaccination, because many of the antibodies actually target the spike protein. So in other words, they're really saying, do you have antibodies to the spike protein, which can occur after infection, but obviously can also occur after vaccination. So you've got to be careful. Some other antibody tests, some of the commercial ones use the nuclear capsid, which is this material as a target, and they can tell whether it's a vaccination or infection. But again, these are complicated and you have to speak to your lab ahead of time. So you've got to be really careful with someone who's been vaccinated in terms of interpreting them. And then don't go and test them routinely after vaccination. We've seen this enormously with healthcare workers. You go out and say, I've been vaccinated and I want to see if I have antibodies. Remember, the antibodies may take a long time to become positive. Some of them may never become positive. You may get false negatives anyway for a number of reasons. And of course, what you really want to measure in terms of your protection from severe disease and hospitalization is really the T-cell response, which is not the antibody response in the first place. So we really don't recommend them. Again, you twist yourself in knots if you go and start looking at them in terms of the antibody levels routinely, at least. So again, please be careful of them, especially after the vaccination. And then this was a last point that the virologist wanted in here in terms of when should you be a bit suspicious and speak to your virology colleagues about saying maybe we should sequence this virus specifically to see if it's a strange subtype or strange lineage. And there's a kind of list of things, but some interesting things again. I'll show you on the next page who to speak to if these happen. But for example, if you notice a patient who's very immunocompromised, maybe they've got, say, some hematological malignancy and chemotherapy, and if they have these kind of persistently positive viral loads, that may be a good time to speak to your virologist and saying, let's investigate this a bit further. Vaccine failures now are going to become very common, so I think that won't be a good enough reason to sequence the virus necessarily alone. But certainly in the beginning, the virologists were much more keen on sequencing these ones and getting more information about whether it is. This is who to speak to if you really do want to. This is a network of genomic surveillance in South Africa. They are a combination of the NICD, the NHLS, various university labs, Stellenbosch and UKZN, for example. You can Google them. They're pretty easy to contact, and if they really do want sequencing, that can be there. But again, I think as this matures, this need for sequencing is a lot less, I think, now. The more routine and surveillance sequencing, obviously the role for that is important and ongoing. So these guidelines are available at Knowledge Hub. If you go into Knowledge Hub, you can look at eLibrary and then click on this. Otherwise, that's the website up there. And then I think that's it. So thanks very much, Andy, and we're happy to take any questions.
Yeah, thanks, Jeremy, and thanks for going through that section so astutely. I think it's always a nice thing to have a refresher, and there was some new stuff there, so that is important for us all to review. There is now time for questions, and it's up to you guys as an audience to put those up. I see only one thing so far as a specific question, or there is some stuff in the chat. So the first question I've got, if I can find it now, is about this guideline being to not test for sporting purposes, but they are concerned about professional sport versus school sport and the practical implications of that. I don't know if you want to comment on that, Jeremy?
Sure. Yeah, so the background to that is what people were doing internationally, and all from that level all the way down to school level and sometimes beyond, was that they're saying, you need a test before we decide if you can play the sport. Now, again, what happens at an international level, that is well beyond the scope of these guidelines, and that may well happen. And you're seeing, I think, increasingly some of the top sportsmen requiring negative tests anyway. So that's really not what it's aimed for. It's really aimed at the national level, where people will say, like, before you play rugby, you need a test. We really don't recommend that as a testing strategy. One is it overwhelms the number of tests required, and you, outside of really the peak, your hit rate is incredibly low. And the other thing, again, is that you're mostly dealing anyway in sporting populations with pretty fit and healthy people for whom exposure to COVID is unlikely to have a bad result. And then, of course, the last part, which kind of hovers over all our guidelines these days and all the decisions, is the kind of increasing realization that this is not a virus that we think is eradicable. And so it really is about trying to get to some sense of normality with it, protecting the most vulnerable without going mad about testing people who are very asymptomatic. Again, totally different if they're symptomatic, of course, in which case, of course, they need tests. But not in general for sport, no.
Thanks, Jeremy. The other question that's come up linked to that is about, I think, vaccine failures and an increased rate of vaccine failures, and a comment about why that might be.
Oh, sorry. So I think then I probably wasn't clear. So what I was more meaning is, as we vaccinate more and more people, the absolute number of vaccine failures will increase, because you can't have a vaccine failure unless you've had a vaccine. So the more people we vaccinate, the more number of people who will fail, but that it's not necessarily a higher percentage, it's just a higher absolute number. And of course, I mean, with time, if the virus continues to mutate, that may be a thing that the percentage changes. But sorry, my comment was really just about that as for example, if we vaccinate 70% of the population, or more, which I sincerely hope we get to, then many of the infections are going to be vaccine failures in big inverted commas. But of course, a vaccine failure is just an infection. The vaccine still may be very, very good at preventing severe disease and death, which is their chief job. Thanks.
Thanks, Jeremy. Now we've also, okay, I'll take that one because that's a very quick one. Vitamin D, zinc, and colchicine to treat COVID. So you're encouraged to look at the website, which we've shown you before, and it will, Trudy maybe will want to cover that as well, but it basically covers what we have reviewed over the course of the last 18 months or so now. And the interesting thing is that these processes need to be repeated as new evidence comes up. Tamara's just posted the link for that there. And the other issue is that even when you have reviewed it, you can actually, as you finish review it, find new evidence. So it's a dynamic process, but we've certainly had a bash at those things. There isn't much evidence either, unfortunately, for any of them at the moment. And we may cover some of them in the webinars later too. What else have we got in the way of questions? Antigen tests available at the admission room, or should they be sent to the lab? I don't know. Do you want to take that, Jeremy?
Sure. How you use antigen tests depends on your specific scenario, but there's no reason physicians at the admission room shouldn't be using them necessarily if that's the quickest way and most convenient way to get the results. Obviously, if you send it to the lab and it's very delayed, then you get rid of the benefit of it being a rapid test. But the key thing is, no matter who does it, is to report the results. There is a link on the NICD's webpage about where to report them. So in other words, if clinicians are doing them at the bedside, they must have a sort of a register of the results, positive and negative, and be entering them electronically day by day. Otherwise, the surveillance goes off. Then we don't know how many people are actually testing positive. So it doesn't matter where they're done and whatever's convenient and easiest at the individual level, but they must just be reported so that the results are known either way, not just the positives, the negatives as well. Thanks.
Yeah, so I'm trying to look at questions at the same time. The question around why we don't advertise in the media that mucolytics and vitamin C have minimal difference. I don't know, Halima, do you want to try and approach that?
Yeah, thanks for that question. I think we try to sort of get information out as much as possible, but I know certainly that when there was a study from the US that looked at a certain antitussive, a study done in animals that may have increased replication of COVID-19, it did appear in the media. But I think you're right, we don't use the media enough to sort of give the results of the rapid reviews. But I think that is something the Department of Health can look into. But what we do is give the rapid review conclusions on Twitter. Yeah, so I think we need to look at more clearly how we use the media to disseminate the information more rapidly. Thank you for that suggestion.
Yeah, okay, thank you. Yeah, the trouble with advertising in the media is it's got two sides to it. On the one side, you actually advertise because you then bring the stuff to people's consciousness, so awareness. And when we say it doesn't work, the message that goes out might in fact be the opposite. So it's a two-edged sword sometimes, and one has to just be a bit careful. And we are thinking quite carefully about how we passing our messages on. And obviously these webinars are one of the ways we are enthusiastic about. Yeah, do oral mucolytics work? Yes, okay, well, I don't think we have much evidence for any of the mucolytics, and certainly I don't think we've got data on oral mucolytics. Again, Halima, I don't know if you came across anything there.
Yeah, no, there isn't any studies to show that, and it's very unlikely that it will work in the setting of COVID. I think currently the best thing that works to release mucus plug is those respiratory exercises and the help of a physiotherapist to dislodge the mucus plug. Thanks.
Yeah, thank you. And what is the evidence of SSRIs? That's a little bit off topic. We are going to look at it, I think, as there are some trials coming out now about them. We'll find out at some stage when the evidence is there. At the moment, I don't think anybody knows. All right. Has anybody else come across any other questions or sites that are maybe missing in terms of issues that people have?
Andy, sorry, I was just saying there's a question in the chat from Dr. Com, if you'd like, about were age and comorbidities taken into account in the vitamin C randomized control trials? So there were, but I think the question is really coming saying, what if we look at that subset of people? The problem is that a lot of these trials were tiny, and so to have a subset of a trial just gives you a totally almost uninterpretable answer. They are in there. If you look at the trials themselves, they do list comorbidities. I don't know that there was any clear signal seen, but I think it would be very difficult to see a signal in a trial so small anyway. I'm not confident there would be one, though, if you did break down by a subgroup like that. Thanks.
I mean, just to finish off from an evidence medicine perspective, once your primary outcome is null, in other words, you're not seeing anything, looking at subsets is really a recipe for misinterpretation. You're very unlikely to get information that you can use, particularly in such a frail data set as Jeremy has mentioned. So the short answer is we've got frail evidence for the main conclusion. Subsets are beyond frail. They're just going to be unbelievable either way. All right. Can a person do hi, Jasmine. Can a person do a patient-friendly rapid review pamphlet? Yeah, I'm sure we could. Anybody want to think about that? Trudy?
So if Yasmina would like to get on board on this initiative, it obviously takes a lot of work. But infographics and information sharing, we do realize is very important, and it's one of the areas that needs to be strengthened in the National Department of Health COVID-19 response. But yes, Yasmina, any ideas? You're more than welcome to share them. Thanks.
Okay, I think we are more or less up to time. I think if there are any other questions and issues that people want to raise, I'm very happy to hear them. But it seems that we've got to the end of our session, and the two speakers have done a very good job of covering those rapid reviews very well. And thank you to Jeremy also for the update on the antigen testing. So essentially, we've got information that neither of the two agents is likely to be particularly productive in terms of their use in COVID. And I think that that's in a way valuable information, although it is negative in a way. But once again, I think just have to thank the speakers. And I don't know if there's any other housekeeping issues that anybody else wants to bring up. But otherwise, we're grateful that you could join us for this webinar, which is the second in our series. And we look forward to your feedback, because that really strengthens the things going forward and allows us to model them more appropriately. Specifically, we are going to ask you about what time suits you. If there's a better time that we can model this around, we'll be keen to do that. Good. Okay.
And the link is in the chat, Andy, as well, for people to give feedback.
Yes, no, thank you. Thanks for mentioning that, Jeremy. And so, okay, so let's call it a day then. And thanks once again to our speakers and to all the people behind the scenes who did the preparation, and to all the people who were here as an audience. Thanks for joining us, and I hope you enjoy the rest of your evening. Cheerio then.